Good evening, everyone. Welcome to another episode of Young Family Physicians Forum. Today, our speaker is Dr. Shobana Sri Sooriyakanthan, Registrar in Family Medicine from 2023 batch. To give a brief introduction on Dr. Shobana, I invite Dr. Imran of the same batch. Over to you,
Thank
Dr.
you.
Imran.
Thank you. Dr. Shobana is a second year registrar in family medicine. She graduated from the University of Colombo and currently serves as a lecturer in the Department of Primary Healthcare Sciences, Eastern University, Sri Lanka. Today, she'll be doing a case-based discussion on the topic bleeding that break the rules. Over to you, Dr. Shobana.
Thank you, Dr. Imran, for the kind introduction. Can you all hear me?
Yes, Doctor, we can hear you.
Okay, then we'll proceed. So today we have two cases for discussion with regard to bleeding that breaks the rules, which are very common in primary care. So let's move on to the first case. This is the case scenario one about a 44 years old laborer, mother of two children, who presented with heavy menstrual bleeding for 3 months. So I shall give you a minute to think about this case and work out some differential diagnosis in your mind. Um, okay, so we'll proceed. So,
No, Shobana.
okay,
So
madam.
this is a discussion, right?
Okay.
Like now I observed for the last few months, nobody's talking. So what's the point of like doing such discussions if you just listen to a lecture? It's not a lecture, it's a discussion, right? I think you all have to talk and you have to explore and like sort of give kind of a brains like it's not a just listen, then you are not like actively participating. Understand? So
Yes.
I think better have a discussion. If you don't do, I'll just log out. Okay.
Okay. Can anyone come up with your ideas? What could be the differential diagnosis for this presentation about a middle-aged woman who presented with this heavy menstrual bleeding for 3 months?
Uh, Submucosal fibroid.
Yes.
And hyperthyroidism.
Like
Hypo.
shall I give kind of a support for you all now? Since you know that I've been like teaching you, I mean, give some guidance to you all when I do some classes. So accordingly, you better answer. Now, where are key things? Now, 44 years old, mother of two, and then 3 months heavy menstrual bleeding. So you have to say, according to these three set of factors, I would like to include this, and I would like to include that. So this something like that. The hypothyroidism, this, that. It's not like very like you just say some. Even a medical student can say like that. I think you have to use your brain the same way that you do an OSCE or a long case or a CQ. Think in the same kind of situation, and maybe 3 months. Why 3 months? And you give some answer. So the age again matters a lot. Why it? What are the reasons? What could be the causes? And then, so this not just heavy means that part is also there, heavy. So whether you have some questions, it is only heavy. Is there any pain? If it is associated with pain, these are my possibilities. So something like that, you have to work it out. Otherwise, see, not just, it is for you all to have kind of understanding how do I do the exam, or after that, after the even MD as senior registrar, when you come across a patient, how do I deal with the patient? very professionally, not like just a medical officer. Right? So you should understand what are the objectives of having this. But Young Family Physicians Forum, what is this, man? It is just to listen and just say and ask some few questions and then go. It's not. See, but my objectives are like totally different when I like start very first time. So better do that. Earlier they used to do that job. Like all the seniors, they did nicely. Actually, I had to like it's with a very great difficulty. I had to stop all these things. Now enough. Now go on. Like they were talking. Should you brainstorm, right? You have to understand. Okay, right. So then I'll give another chance. You all to talk. Otherwise, it's just a waste of time.
Dr. Shobana,
Yes.
any other symptoms such as
No. Don't ask any other symptoms, Angelica. With the available, what are the things? Then she will say the other things. Right? Availability, because these are my sort of my according to these things, these are the possibilities. Then this is the way we ask even as CQ. So what were the questions you ask together from the patients to arrive into diagnosis and the clinical manifestations? Something like we just did second part. So then it's think of this could be the same thing like your exams, right? Okay.
so I think out of the palm coin uh, etiologies in this patient, given the age and that the short duration of 3 months, something leiomyomata is high up in the list because it could cause continuous bleeding for 3 months in this age group.
Yes, possible. Any other differential diagnosis you are thinking of other than leiomyomata?
Other structural lesions such as cervical polyps, endometrial polyps, even endometriosis
Yes.
also possible. And hormonal abnormal like dysfunction, uterine bleeding also possible. And bleeding disorders also possible.
Bleeding disorders is, I think it's unlikely because he has two children. If it is there, it would have been, it had been manifested there while delivery, unless it is acquired recently.
Yes, acquired lesion, not hereditary.
Any possibility of drug induced?
Yes, could be. What are the drugs you are specifically asking for?
Or is she on any warfarin or clopidogrel, right?
Okay.
It could even be adenomyosis.
Yes, possible. Yes.
Is it regular bleeding or is it like breakthrough bleeding?
Sorry, what did you ask for me first?
Was it regular periods or is it breakthrough?
Regular? No, it's a regular period with heavy menstrual bleeding flow.
She has any hypothyroidism in features?
Not a diagnosed patient, so I will be dealing with the history whether she's having any symptoms. But it's a possibility. Yes.
Any contraceptive methods she recently used? Any like Jadel or any injectable things?
Yes, possible, but she had underwent LRT after her second child.
So you can give information later. Just there are possibilities. You keep it in your mind, and then now give the possibility.
Yes.
Continue this.
Could be endometrial CA.
Yes, possible. So, with those in mind, we shall proceed with the history. As it is relevant, I'll start with the menstrual history. She had regular menstrual cycle for every 30 days, lasting for 3 days, where she used 2 to 3 pads per day. That was her usual cycle. But over the past 3 months, she has noted, though her cycles remained regular, it lasted for 10 days where she had to use around 8 to 10 pads per day. Sometimes she used double protection. And as it has affected her quality of life severely, she avoids going to work during these days with heavy flow. Apart from that, she has no abdominal pain, no intermenstrual bleeding or postcoital bleeding. And she had her last regular menstrual period 1 week ago, and she is still having bleeding. And she had no loss of weight or loss of appetite, no associated vaginal discharge or pruritus, no history of trauma, instrumentation, or the sexual intercourse, no history of epistaxis or easy bruising, no symptoms of hyper or hypothyroidism, and she is not on any hormonal replacement therapy or any long-term medication such as anticoagulants. And she had complained of abdominal bloating and regurgitation for the last 3 months, but she denies dizziness or shortness of breath on exertion. There is no urinary symptoms, urgency, dysuria, or frequency. Her bowel movements are normal. And apart from that, she complains of feeling more sweatier at nights and getting easily irritable for the past 6 months. Okay. She had 2 normal vaginal deliveries, no postpartum bleeding, and she has breastfed the 2 children for 2 years. And there is no significant past medical history. And other than bilateral LRT, she has no past surgical history and no history of allergies or family history of gynecological malignancies or bleeding disorders. She is a daily paid laborer in a private company and she prefers to stay inside the house during heavy bleeding days. And she denies any stress or increased workload at workplace. And husband went abroad 2 years ago for financial crisis. Now she's living with her daughter and the grandchildren. So this is the summary. I have put her important events of her life cycle in a timeline. And she's a 44 years old laborer, mother of 2 children, presented with heavy menstrual bleeding for 3 months. Now, can you all narrow down your diagnosis and come up with a few most probable differential diagnoses for us to proceed with the examination?
I think hyperthyroidism is high up in the list at the moment.
But she denies any symptoms of hyper as well as hypothyroidism, both called heat intolerance, and no neck enlargement, no hand sweating, and there is no ankle edema, no hair loss.
She mentioned about sweating, right?
Yes, she felt sweating more at nights, and
Nice.
yes,
Perimenopausal bleeding.
uh, could be in the list, yes.
So we can exclude hormonal, imbalances because the cycles are regular, so nothing to do
Mm,
with ovaries. So it
yes.
could be either coagulopathy, which is secondary to maybe drug-induced, or anything structural like polyp, or maybe other uterine structural diseases like adenomyosis or uterine polyp fibroid, anything
Mm,
like that, because the cycles are regular. And
yes.
was there any passage of clots?
Yes. Only on the initial days, she had lots.
Okay.
Still, my differential diagnosis up in dysfunctional uterine bleeding is the first one.
Mm, okay.
Any symptoms suggestive of early menopause? Any supportive symptoms?
Other than the 2 symptoms that I have mentioned, she denies all the other vasomotor symptoms. Only these night sweats and easy irritability was there. no dry vagina or painful. No other urinary symptoms. And
Excluded pregnancy?
she's she had her regular menstrual bleeding 1 week ago and still having bleeding, and she had underwent bilateral LRT, as well as she denies any sexual intercourse because her husband also went abroad 2 years ago. So after that, she denies any sexual contacts. Still possible. If very low in the list. But yeah. So we
But
have
anyway, we have to exclude by doing.
yes. Yeah, I accept. Okay, so with those in mind, I proceeded with the examination. So on general examination, she was afebrile, not pale, no angular stomatitis or glossitis. Pulse rate 92 beats per minute, regular, good volume, and blood pressure was 120 by 80 millimeter mercury. And on abdominal examination, there was an abdominopelvic mass which was firm, 14-week gravid uterus size, and there was no ascites. Vaginal examination done, vulva and vagina appeared normal. Cervix was firm, healthy, no cervical motion tenderness. Bimanual examination done, uterus antevated, enlarged uterus with 14-week size and no adnexal masses, and there was active bleeding. So, with the history and examination, we came to a probable diagnosis as the patient having fibroids, with a clue that it was a painless, heavy menstrual bleeding with an abdominopelvic mass of 14-week gravid uterus. So we ordered a full blood count, ultrasound scan, abdomen and the pelvis. And to control the acute bleeding, medical management was done with the tranexamic acid 1 gram TDS and the mefenamic acid 500 milligram TDS. And a follow-up visit was arranged to review the investigation. And she came up with the investigation. Full blood count showed white blood cell count of 4 into 10 to the power 9 per liter, hemoglobin of 12.3 gram per deciliter, platelet 231 into 10 to the power 9 per liter. And the trans-abdominal scan revealed evidence of 2 large posterior wall fibroids measuring 6.3 into 5.5 centimeter and 5.2 into 4.8 centimeter. So we have educated the patient on the cause of bleeding as fibroids, and she was concerned whether it's a carcinoma, and we have reassured her as a benign condition, and we have discussed the management options with her. And patient had no comorbidities or no fertility wishes, and she prefers to go for surgery and gynecological referral done at that time. Meanwhile, we continued the medical management with tranexamic acid and mefenamic acid starting from the first day of menstruation and asked to continue for the days with heavy bleeding. And she complained of these perimenopausal symptoms. So we did the opportunistic health promotion. We discussed with the perimenopausal symptoms and the management options we have. So we arranged a follow-up visit, discuss about the hormone replacement therapy and the other treatment options, and to accompany with her daughter in the next visit, and to discuss about the occupational health issues as well. Okay, so shall we move on to the next case? So this is also a similar case, but the working will be the presentation will be different. It's about a 54 years old mother of 4 children who attained menopause 5 years ago, presented this time with bleeding per vagina for 10 days. So, can you all give us the most probable diagnosis for this presentation?
First, we have to exclude the sinister causes like endometrial or cervical cancers.
Yes.
But the most common cause is atopic vaginitis.
Mm. Yes. Any other differential diagnosis?
Cervical or endometrial polyp.
Yes. Some more to add on.
It may be due to drug induced.
Yes.
Sometimes they may be taking medicines like aspirin, warfarin.
Yes.
Shobana, wait for 1 minute and go ahead. Like, so then if there's it, I wonder that how if we put this thing to a SAQ, how they answer, right? That's my question now. Okay, go ahead.
She had her spontaneous vaginal bleeding for the last 10 days, and there were clots, and she had to use around 6 to 8 pads per day, sometimes with double protection. But she had no associated abdominal pain or shortness of breath or dizziness. And there was no loss of weight or loss of appetite, no history of epistaxis or gum bleeding or other bleeding manifestations, no hyper or hypothyroid symptoms, and there is no history of chronic back pain, pervaginal discharge, or fever. And she denies sexual abuse, and there is no history of trauma, instrumentation, or the sexual intercourse. And she is not on any hormone replacement therapy or long term medications. And she had no urinary symptoms, urgency, frequency, and the dysuria. Normal bowel movements are there. And she complained of sleep disturbance, difficulty in getting to sleep, but there was no early morning awakening. And she denies mood changes, irritability, or symptoms suggestive of hot flushes. And she had no loss of interest in pleasurable activities. Okay. So she had a regular cycle previously, which was in every 30 days, and she bleeds for 3 days, and she uses around 2 pads per day. With there was no abdominal pain, and after 48 years, her cycles became irregular, and she had no bleeding since 49 years. And she married at 17 years and had her first pregnancy at 22 years and 4 normal vaginal deliveries within 6 years. And it was not complicated with any bleeding. And she breastfed all 4 children for 2 years. And there was no significant past medical history. And she had underwent bilateral LRT in the postpartum period and no allergic history, no family history of gynecological cancer, but father had oral cancer and no bleeding disorders in the family. She's a daily paid servant, educated up to grade 5, and her husband got separated 20 years ago and due to marital conflicts. And all 4 daughters got married now and they are living nearby, but she is currently living alone. Okay. So this is the summary. 54 years old, mother of 4 children, who attained menopause 5 years ago, presented with bleeding per vagina for 10 days. Okay. So as you all said, we had differential diagnosis of atrophic endometritis or vaginitis, endometrial CA, endometrial or cervical polyp, endometrial hyperplasia, vulvovaginal cancer, cervical cancer, and the sexual trauma and the abuse. So we proceeded with the examination. Her BMI was at 22.5 kilogram per meter squared. She was afebrile, not pale, no angular stomatitis or glossitis. Pulse rate is 88 beats per minute, and the blood pressure is 130 by 90 millimeter mercury. And the abdominal examination, it was a soft abdomen with non-tender or no palpable masses. Vaginal examination, vulva and vagina appeared normal, cervix was firm, irregular, no cervical motion tenderness. And we proceeded with the bimanual examination. Uterus anteverted, normal in size, no masses in the adnexia, and there was active bleeding. Okay. So at this point, we ordered full blood count and ultrasound scan abdomen and the pelvis. And to control the acute bleeding, medical management was done with tranexamic acid and the mefenamic acid. And we advised her on the sleep hygiene and the diet, and arranged a follow-up visit to review the investigations and to accompany with her daughter. So she came up with the investigation with a full blood count showing WBC of 6.5 into 10 to the power 9 per liter, platelet 276 into 10 to the power 9 per liter with a hemoglobin of 12.1 gram per deciliter. And the scan showed an endometrial thickness of 12.4 millimeter with a uterus size of 10 into 4.8 into 7.5 centimeter with no adenomyotic changes or fibrotic changes. So the patient was explained about the ultrasound scan findings and the risk of endometrial cancer. And at this point, we did the gynecological referral for further biopsy and further management. So we followed up the patient. She underwent dilatation and the curettage, and the histology revealed moderately differentiated adenocarcinoma. And they planned for a total abdominal hysterectomy. So we explained her about the surgery and the risk of endometrial cancer for family members, especially her daughters, and addressed the socio-economic concerns with her family members. Okay. With that, we shall proceed for the discussion of these two cases. We are a short explanation of the normal physiology and the pathophysiology of these case scenarios will be discussed. You all are aware of the normal physiology of this menstruation, but we'll have a recap. So the HPO axis, where the hypothalamus secretes the GnRH, which stimulates the anterior pituitary to stimulate the FSH and LH, which acts on the ovaries to produce the estradiol. In the normal menstrual cycle, it has 3 phases. So in the first follicular phase, this FSH level increases and it causes the dominant follicle to mature and produce estrogen by the granulosa cells. So with the elevation of the estrogen levels, the menstrual flow ceases and the endometrium proliferates, and a positive feedback will be exerted on LH, resulting in the ovulation. So during the luteal phase, the progesterone level increases, which halts the proliferation of the endometrium, promoting its differentiation. When the progesterone production by the corpus luteum diminishes, it causes the endometrial shedding and the normal menstruation. So the FIGO explains the menstrual cycle with the 4 main terms, that is the frequency, regularity, duration, and the volume of flow. So these are the terms that are currently used by the FIGO. When they describe about the frequency, it normally is considered as 24 to 38 days, and less than 24 days is a frequent, and more than 38 days is an infrequent cycle. And regular cycles are considered with a variation of plus or minus 2 to 20 days over 12 months. And it's considered a variation of more than 20 days over 12 months as irregular cycles. And normal duration is 4.5 to 8 days. When it's less than 4.5 days, it's considered shortened. And when it's more than 8 days, it's considered a prolonged cycle. And the 5 to 80 millimeter of blood is lost normally. And when it's less than 5, it says light. And when it's more than 80, it's considered heavy. But the term heavy menstrual bleeding is characterized by the bleeding that interferes with the patient's quality of life. So any irregularities in the menstrual cycle involving the frequency, regularity, duration, or the volume, they are in a non-pregnant woman, they are termed as abnormal uterine bleeding. So currently other terms are not in use. Dysfunctional uterine bleeding, dysmenorrhea, those terms we are not using. Okay. So abnormal vaginal bleeding, broadly the causes can be first as we came across many ideas of pregnancy, we have to exclude the pregnancy because it can be a complication of pregnancy, like ectopic miscarriage, gestational trophoblastic disease, or the placenta previa. And infectious causes, cervicitis or the endometritis, it could be due to trauma, laceration, abrasion of the foreign body, instrumentation, sexual intercourse, and or it could be a benign pelvic pathology, cervical polyp or the endometrial polyp, or malignant conditions like vulvovaginal cancer, cervical cancer, endometrial, or the ovarian cancer. Apart from this, we have to always think of the systemic causes like hepatic diseases, renal diseases, coagulopathy, thrombocytopenia, von Willebrand disease, leukemia, hypothyroidism, hyperprolactinemia, Cushing's disease, polycystic ovarian disease, adrenal dysfunction or the tumor, or the stress, excessive exercise, or emotional. And the medications or the iatrogenic causes like hormone replacement therapy, oral contraceptive pills, progesterone only pills, anticoagulants, antipsychotics, and selective serotonin reuptake inhibitors, corticosteroids, tamoxifen, and the intrauterine devices. So, palm coin classification, which is established by the FIGO, it helps us in diagnosing and managing the abnormal uterine bleeding in non-pregnant women. So the left side of this image will give us the structural causes like polyp, adenomyosis, leiomyoma, or malignancy, which is explained as the palm. And the non-structural causes like coagulopathy, ovulatory dysfunction, endometrial causes, iatrogenic causes, or the non-specified causes, they are considered non-structural causes with the term coin. So we'll have a look of each of these causes. And the AUBP is termed as abnormal uterine bleeding causative agent of polyp. It could be an endometrial or endocervical polyps. They are focal outgrowths of tissue, and they are maybe asymptomatic, sometimes cause intermenstrual bleeding. And most of them are benign, but they occasionally carry a malignant risk. This adenomyosis, this is the presence of endometrial tissue within the myometrium. So it's associated with heavy, painful, or prolonged menstruation and may result in uterine enlargement. So in our case, the patient did not have any pain. So the adenoma, the fibroid was more likely than the adenomyosis when we work up in the history. And leiomyoma, commonly known as fibroids, they are benign smooth muscle tumors. They can lead to heavy or prolonged menstrual bleeding, particularly if they are large or submucosal. And many of them are usually asymptomatic. And AUBM malignancy or the hyperplasia, they include endometrial hyperplasia and the cancers, often presenting with unpredictable bleeding. So the risk factor include prolonged estrogen exposure without opposition by the progesterone. So we'll now have a look at the non-structural etiologies. Coagulopathy, the systemic bleeding disorders, von Willebrand diseases, they are common causes of heavy menstrual bleeding, particularly in the adolescents and the young adults. And ovulatory dysfunctions like polycystic ovarian syndrome, hypothalamic disorders, thyroid dysfunction, and these can lead to infrequent, irregular, heavy, or prolonged bleeding due to inconsistent ovulations. So they are also more common in all the age groups. And endometrial disorders, these involve the localized issues in the endometrium. So the ability to control bleeding, possibly due to the inflammation, infection, and the vasoconstriction abnormalities. And the iatrogenic causes, medications, hormonal contraceptives, anticoagulants, or tamoxifen, or the surgical injury, Asherman syndrome, can induce the abnormal bleeding. And there are non-other classified causes like arteriovenous malformation, or the chronic endometritis, or the cesarean scar defects. So when we assess a patient with abnormal uterine bleeding, first we have to assess for the hemodynamic stability and anemia, because they can present with heavy menstrual bleeding. So it could be severe enough to cause a hemodynamic instability. So first of all, we have to exclude that the patient is not hemodynamically unstable. Then exclude the pregnancy and identify the source of bleeding and determine whether the endometrial cancer evaluation is needed or not. If the patient is hemodynamically unstable and there is refractory bleeding despite outpatient management 24 hours, like saturating more than one pad in an hour or bleeding through a pad within 2 hours, or the hemoglobin less than 8 gram per deciliter, or signs of hypovolemia or orthostatic hypertension, they may need hospitalization and emergent interventions to control the bleeding. It could be with include mechanical control with intrauterine tamponade using a balloon Foley catheter or gauze packing. The high dose medical interventions like intravenous or oral estrogens if not contraindicated. COCP, oral progestins, or the IV tranexamic acid. So if they are stable, we have to exclude the pregnancy, and for all patients do a full blood count routinely. But other investigations like ferritin, clotting profile, thyroid function test, or the female hormone testings, they are only indicated if there are clinical, if we need to do it clinically, if there are history and examination is suggested. Otherwise, for patients with less than 45 years, they don't want any further investigations. We can treat and wait. But if they are more than 45 years, they always need an evaluation for endometrial CA. The first line is the imaging with trans-abdominal scan or the trans-vaginal ultrasound scan to assess the endometrial thickness, and with that we can diagnose leiomyomas and the adenomyosis. And if needed, we have to proceed, if it's indicated, we have to proceed with the endometrial biopsy. It could be office-based endometrial biopsy or the people biopsy or hysteroscopic biopsy. And if the cervical smear is overdue or swabs, we have to take if clinically indicated. So when it comes to managing a patient, we have to consider several factors. First is the underlying cause and the acuity of bleeding, fertility, contraceptive goals, comorbidities, the treatment efficacy, adverse effects, and the cost. And treatment is indicated when the abnormal uterine bleeding leads to anemia or significantly impacts the patient's quality of life. And when we have an identifiable cause, when it's treated, symptoms usually resolve without any additional intervention. So, the treatment includes both the medical and the surgical management. When there are no structural abnormalities, when the fibroid is less than 3 centimeter, we can proceed with the medical management. And it's usually preferred in patients who avoid surgery and when we want to preserve fertility. And there are hormonal and non-hormonal treatment options. So the levonorgestrel intrauterine system is the first line medical management for chronic abnormal uterine bleeding with no identifiable pathology. And adenomyosis, and for the fibroids less than 3 centimeter not disturbing the uterine cavity. And it's the most effective type of treatment. It controls the bleeding in 71 to 95% of blood clots is reduced. And when they have irregular cycles, we prefer to go for the combined oral contraceptive space. It's also effective for reducing the blood loss and regularize the ovulatory dysfunction. And there are options for progestin-only therapy with continuous oral progestin, including medroxyprogesterone 2.5 to 10 milligram, noethistérone 5 to 10 milligram daily, or dipomedroxyprogesterone 150 milligrams subcutaneously every 3 months. But it's a short-term treatment option to stop the bleeding, so it often results in lower patient satisfaction. And when it comes to non-hormonal treatment, tranexamic acid, 1 to 1.5 5 gram orally every 8 hours can be given. And we ask the patient to start on the day 1 and continue for the days with heavy flow, because 80% of the blood is lost within the first 3 days. And tranexamic acid reduces the blood loss by 40%, and it's suitable for the patients who are attempting conception. And when the patient complains of pain, we prefer to go for the mefenamic acid, non-steroidal anti-inflammatory drugs. 500 milligram 3 times daily with food can be given. And it's also started on the day 1 and continue for days of heavy flow. And it can reduce the bleeding by 20 to 30%. Okay. So there are several surgical management options. Hysteroscopic or laparoscopic myomectomy, that is excising the leiomyoma while retaining the uterus. So it's performed to preserve the fertility. And uterine artery embolization, where the bilateral uterine arteries are catheterized and the blood flow is occluded with particulate material. So it's considered particularly for the leiomyomas. And endometrial ablation, where the endometrial lining is destructed, and it's not recommended for those who are desiring for fertility. And microwave ablation, thermal ablation, or NovaSure can be there are options. And hysterectomy, this is the definitive solution with high satisfaction rates and frequently considered for adenomyosis in those who do not desire fertility conservation. And with that, we'll also look at the etiology-specific treatment. Polyps, surgical resection can be done. Adenomyosis, primarily hysterectomy, but rarely adenomyomectomy can be done. Leiomyomas, management can be either medical or surgical. It depends on the patient's factors. The fertility wishes, the medical comorbidities, whether there are symptoms from uterine pressure, distortion of the uterine cavity, the comorbidities of the patients. And when there is normal uterus with a small fibroid less than 3 centimeter in size, we can proceed with an endometrial ablation. But when the fibroid is large, more than 3 centimeter, uterine artery embolization or the myomectomy, and these two retain the fertility. And when there is no response to intrauterine system levonorgestrel and above medical or surgical management, we have to proceed with the hysterectomy. And we have medical options, levonorgestrel IUD and GnRH agonist, systemic progestins, ulipristal acetate, tranexamic acid, and the NSAIDs. And when we talk about these GnRH analogs, they can be used for moderate to severe symptoms. But the period we have to limit for 6 to 12 months, and it's costly. And when we can use this ulipristal acetate, it's intermittent treatment of moderate to severe symptoms. And when the surgical management has failed or not possible, this is considered, but it causes liver injury. So we have to do the liver function test before starting and in the first 2 courses. So it is given as 5 milligrams 4 courses. So then the endometrial hyperplasia, the malignancy or the hyperplasia. So the treatment includes surgery with or without adjuvant therapy. It depends on the type of malignancy and the staging. So for cases where the surgery is not feasible, high-dose progestins or the palliative treatments, radiotherapy may be considered. Coagulopathies, von Willebrand disease can be treated with tranexamic acid or the desmopressin, and the ovulatory dysfunction, it focuses on treating and addressing the underlying conditions, including lifestyle modifications for patients with obesity, polycystic ovarian syndrome, or other causes of anovulatory cycles, and the correction of endocrine disorders like treating with levothyroxine for hypothyroid patients. As there are no specific treatments are available for endometrial disorders because the mechanisms are still not fully understood. And the iatrogenic causes, it depends on the causative factor and the severity of the bleeding. For example, when it's a breakthrough bleeding following the initiation of combined oral contraceptive pills, it just requires reassurance initially. And there are other otherwise classified causes like arteriovenous malformations that can be treated with uterine artery embolization. So, so far now we have seen about the heavy menstrual bleeding, the bleeding in middle-aged women. What are the causes for this abnormal vaginal bleeding and the abnormal uterine bleeding? The palm coin classification by the FIGO. and how we are assessing a patient when they present with an abdominal uterine bleeding in the primary care, the hemodynamic instability and excluding pregnancy and looking for the causes and managing the causes. We have the medical and the surgical options, and we have looked at the management options specific for the palm coin classification. So, with that, we shall proceed to the next case about the postmenopausal bleeding. So, menopause, this is the permanent cessation of menstruation that results from the loss of ovarian follicular activity. So that leads to decline in the production of estrogen and the progesterone, which leads to the presentation of somatic, sexual, and the psychological symptoms that impair the overall quality of life of the woman. So the average age in Sri Lanka is around 49 to 51 years. So, any bleeding that occurs after 1 year of amenorrhea in a woman who is not receiving hormone replacement therapy is considered postmenopausal bleeding. And 1 in 10 women with postmenopausal bleeding will have endometrial cancer or atypical hyperplasia. So the assessment include a complete history with the assessment of risk factors as well as the medication history, covering the use of estrogen, tamoxifen, or the anticoagulants. Okay. So when it comes to causes of postmenopausal bleeding, as you all correctly mentioned, it's 60 to 80% of the time it's atrophic endometritis and the vaginitis. But we should not miss the endometrial carcinoma, which accounts to 10% of the time. And the other causes are the exogenous estrogens, endometrial hyperplasia, endometrial or the cervical polyps. And especially we have to think about in this age group about the trauma, sexual abuse, instrumentation, and urethral caruncle, uterine sarcoma, cervical cancer, vulvovaginal cancer, and other treatment. All the causes that we have discussed about the systemic causes and the medications is applicable here as well for the postmenopausal bleeding. Okay. So the risk factors of endometrial cancer. So we have to ask in the history about the parity, nulliparity, late menopause, obesity, diabetes mellitus, polycystic ovarian syndrome, hereditary non-polyposis colorectal cancer, unopposed estrogen therapy, tamoxifen. So examination includes BMI, blood pressure, and the signs of anemia. And the abdomen, we have to look for the any masses, abdominal pelvic masses, and the ascites. And we have to do a speculum examination to look for the vulva, vagina, and the cervical pathology and the polyps. And do a bimanual examination to assess the uterine size, mobility, position, and the adnexal masses. Okay. So the common causes are the atrophic vaginitis, which is thinning and inflammation of the vaginal wall due to reduced estrogen levels. So we have to treat with a topical or systemic estrogen. And cervical polyps, the endocervical polyps are commoner than the ectocervical polyps, and 90% of the time they are benign. But we have to remove them when they are more than 3 centimeter and symptomatic and considering a slight increased risk of cancer. So endometrial polyps, they are usually asymptomatic, and severity of the postmenopausal bleeding is not affected by the size or the number of endometrial polyps. And 1% of them are malignant. And when they are symptomatic or when there is a high risk of malignancy, we have to remove and send for histology. And the hysteroscopic polypectomy is the preferred treatment because we can directly visualize and remove the polyps. Endometrial hyperplasia, currently there are only 2 classifications, whether it's with atypia or without atypia. If it's with atypia, there is a 20% risk of cancer. So we proceed with the treatment of hysterectomy with or without oophorectomy. If not fit for surgery, we have to treat with high-dose progesterone. And if there is no atypia, 80% of the time they respond to progesterone. Okay. So assessment of a patient presenting with postmenopausal bleeding, first check whether the patient has up-to-date and normal cervical screening and normal cervix and the vagina on the speculum examination. And we can request for the ultrasound scan to assess the endometrial thickness, as we have done in this case. So when the endometrial thickness is less than or equal to 4 millimeter, then we have to ask for the risk factors with either they are present, like all age group, non-users of HRT, regular endometrial thickness, fluid in the cavity, or hemo or pyometra. If the endometrial thickness is also less than 4 millimeter and there are no risk factors, there is no need for endometrial sampling. And we can discharge the patient and we have to re-investigate if there are further bleeding. But even in the absence of endometrial thickness being less than 4 millimeter, if they have risk factors, they may need the endometrial sampling. And endometrial thickness, if it's greater than 4 millimeter, we have to proceed with the endometrial sampling, pupil biopsy or the hysteroscopy and biopsy. When we have got the sufficient sampling, the management depends on the histology. And if there is insufficient sampling, we can proceed with the inpatient hysteroscopy and the endometrial sampling. And when it comes as a non-benign histology like hyperplasia or malignancy, the treatment management depends on the histology. But still, when it goes to benign histology or hysteroscopic evidence of atrophy, we can discharge the patient with no further action and reinvestigate if any further bleeding occurs. So this is how we evaluate a patient with postmenopausal bleeding. And indications for endometrial biopsy in postmenopausal bleeding: when the endometrial thickness is more than 4 millimeter in transvaginal ultrasound scan in postmenopausal bleeding, or when there are risk factors for endometrial carcinoma, when there is persistent or recurrent postmenopausal bleeding despite endometrial thickness less than 4 millimeter, and when we have inadequate visualization of the endometrium in the imaging studies. So, when looking about this endometrial cancer, the global incidence of endometrial cancer is increasing primarily due to the increased prevalence of the endometrial cancer risk factors like obesity and the late menopause. And the number of patients diagnosed with endometrial cancer is anticipated to double by the year 2030. So 90% of the time they present with vaginal bleeding. Either it could be postmenopausal bleeding or irregular perimenopausal bleeding or heavy menstrual bleeding in a middle-aged woman. The FICO staging for endometrial cancer and the prognosis. Stage 1 is considered when the tumor is limited to the endometrium and the myometrium. And the stage 2 when it involves the endocervical gland and the cervical stroma. And the stage 3 when it involves the cirrhosis of the uterus, adnexia, or the vaginal metastasis, or the pelvic or para-aortic lymph nodes. When it involves the bladder and the bowel mucosa or the distance, it's considered the stage 4. And the 5-year survival decreases with the staging. And complete surgical staging is done, and it includes the peritoneal cytology, total abdominal hysterectomy, bilateral salpingo-oophorectomy, bilateral pelvic and para-aortic lymphadenectomy. And when it's a complete surgical staging is done, it reduces the need for adjuvant radiotherapy. Usually the prognosis is good because they present early with the bleeding, and usually in the stage 1, so they have a 85% of 5-year survival rate. Population screening with biopsy or the transvaginal ultrasound scan is not recommended because it's not cost effective, and it's considered and useful for the patient, high-risk patients like those with hereditary non-polyposis colorectal cancer family history. So let's also have a look at this unscheduled bleeding when they are on the hormone replacement therapy. Those with unscheduled bleeding on HRT, we have to assess the cancer risk factors, HRT regimen, and the duration and the compliance, and examine if there is major and minor risk factors for endometrial carcinoma, like major risk factors BMI more than 40 and hereditary non-polyposis colorectal cancer. Minor risk factors are BMI 30 to 40, diabetes mellitus, and the polycystic ovarian syndrome. When they have these one major or three minor, we have to do the urgent ultrasound scan. So here the cutoff is when they are under sequential hormone replacement therapy, endometrial thickness is considered, the cutoff is 7 millimeter. And the combined continuous hormonal replacement therapy, endometrial thickness is considered, the cutoff is 5 millimeter. So if it's more than that, we have to refer the patient for endometrial assessment. If it's not, we can optimize the hormone replacement therapy for the next 6 months. But if they are not having these risk factors or having heavy or persistent bleeding or two minor cancer risk factors or more than 6 months of starting the HRT, and we have to do an urgent ultrasound scan. And the scan again the cutoff proceeds, and if they are less than the cutoff, we can optimize the HRT. But if they are within if they don't have any major or minor risk factors and they are within the 6 months, we can optimize the hormone replacement therapy for the 6 months. That is reducing the estrogen dose or increasing the dose of progesterone or changing the time. And or we can consider this 52 milligram levonorgestrel IUD for endometrial hyperplasia. So those are the things we thought to discuss with these two cases. So the take-home messages are: any woman over 45 years presenting with abnormal uterine bleeding requires evaluation for endometrial pathology, including cancer. And the post-menopausal bleeding is considered endometrial cancer until proven otherwise. And do transvaginal ultrasound scan. This is the first-line imaging tool to assess the endometrial thickness. And never ignore irregular bleeding in a middle-aged woman or the post-menopausal bleeding in an older woman. Thank you, Madam.
Yes, actually, Shobana, it's a very precise and very informative presentation. This is actually why we want to do this kind of discussions. As I mentioned, everybody, all the listeners should, of course, they have to use their so the minds, or so they should be, they actively participate, as I mentioned at the beginning. So with this, all the information you sort of presented, I think better. But what are your references? Did you mention the references?
Yes, madam. I used the FIGO reference as well as the American College of Obstetrics and Gynecology, and as well as the Sri Lankan College of Obstetrics and
and the I mean the years and all sort of things, the latest ones and all.
Yes, madam. I used the 2023
Mm-hmm.
and for some 2024, madam.
Okay, so this is a very current knowledge. Now you actually you also gathered a lot of information, and it's your knowledge, of course. I know now it's very, since you have studied that topic, it's good. And then I don't think that anybody who is facing for the exam, you don't have to refer any book. If you can go through this kind of presentation, is more than enough. So that's one idea of doing this. So you listen second time, and you should know if they ask what were the questions you should ask. Then offhand, of course, you cannot give all the answers. But anyway, when you go through this kind of presentation, this is not just one textbook or one guideline. It's sort of everything from each and every sort of, because she has given some references. So I think it's a very enough knowledge for your exam regarding this kind of presentation. You don't have to refer for any other book. So actually, this is why I told you, Shobana, you had to be very very informative without wasting somebody's time. Now you have done your job correctly. And thank you very much for that. And anybody needs to talk or anybody needs any clarification? And one more thing, yeah, you better ask, like this. What about the participation in your batch? How many of you are like in your batch, Shobana? How many are there?
Wait, madam.
Just go through that. Or the one of your colleague can tell. How many of you all in your batch? Imran, how many are there in your batch?
5, madam.
Yes, very interesting. Very interesting. Okay, right. So, right, it's up to you all. Okay, fine. Okay, what somebody actually wanted to ask some question. That means they have very good knowledge, right? So that's why they want to do not to participate for this kind of presentations.
Madam,
Okay, so then when their turn comes, I also think that, okay, fine. They are
Madam,
very, I
Madam,
mean,
we have 10 participants from our batch, madam.
We have
okay.
10, madam.
Right. So then it's, like you have to understand, it's for y'all. So this time only, this batch sort of, they have only less than 6 months for their exams. Well, then they are coming for this. But anyway, when your turn comes, then you feel what will happen to us like. It is not like, sit in one corner and reading a book. You get a lot of information within like 1 hour. That's which we have to actually thank. We have to thank the presenter. So there's a huge work, and like maybe more than 10 hours of reading. And when I ask them to do this change, that change, and all, they have to do it. No, but anyway, ultimately, everything it's for your sake. Okay, 10, of course, at least, maybe more than 50%. Just because I don't want to sort of force you, but it's for y'all. Why I'm wasting my time? Again, it's for y'all. Okay, right. The one actually wanted to ask a question. I saw somebody leaving, somebody joining, leaving. I don't understand this. Okay, fine. Anybody like I noticed somebody wanted to ask questions. Okay, fine.
Dr. Shobana, regarding stanexamic acid,
Yes.
is it indicated for all age groups, or is there sort of provision in elderly because of risk of cardiac ischemia?
Usually, it's indicated for all in the perimenopausal group and the postmenopausal, not the very elderly age group. And in the young, when they are at the menarche, we are usually trying with combined oral contraceptive pills, because the cause is like they are hypothalamus pituitary ovarian axis is not matured. So we proceed with the COCP. We regularize the cycles for 3 months, and with that they become okay. And when it comes to middle age, we are recommending the medical management and even the menopausal, but not for the elderly age group. Like very odd.
I think Helika asked that question. Is it? Is that Helika? Was that
madam.
Helika? Huh?
Yes, madam.
Okay, why did you ask that question? You have some concerns, I suppose.
Madam, because as a side effect of stanexamic, there is an increased risk of.
So shall I put it that I want to ask a question from you all. Other than the bleeding, PV bleeding, are there any indications for tranexamic acid?
In life-threatening bleeding, madam, it is indicated.
Just without just telling something, think and tell me. Or else if you don't have the answers, better go through and then you will realize why did you ask that question. Because I thought because having that in your mind only you ask that question. That's why I asked who asked the question and why did you ask that question. It's a good question, but I don't know whether you have got the point and asked that. Then I asked a question from your batch. What are the other indications for that particular medicine? Okay? Right. When I get you all, I ask that question. Okay. Right, so Shobana. Anybody knows the answers that I told, asked that right now?
And it's also indicated for the treatment of hereditary angioedema and other hyperfibrinolysis, like other conditions as well. Because
not only that, yeah, angioedema means what ultimately?
Bleeding.
Not bleeding, man. What angioedema? Anybody? There's year 3 registrars who are facing the exam in 6 months. Okay. Right. You better find the place. Then now she nicely came to some extent.
Symbolism.
She came to the, she nicely just touched the part, not whole thing. Right. Okay. Right, therefore, because it's definited totally not the same topic. It's a totally different aspect, right? Because of that only I don't want to talk about this. You better find and let me know. Right, Rich, you are coming for the classes now? Right, then I'll ask that question. Okay, right. So then the others, if you don't have the questions, you better finish it off or else wind it up or else what the marathon hard this me. Anyway, or else you ask questions. I don't know.
Thank you, madam. Thank you for the guidance of preparing this presentation. And I have to thank the Sri Lankan College of Specialist Family Physicians also for giving me this opportunity, and the organizing team for your dedicated work and support, and all the participants for your valuable presence. And thank you once again, madam.
Okay, then I think you all should get the maximum benefit of this kind of presentation. And I wish you all the best. Why I ask question, why I sort of, it's not I demand you to come, but it's for your sake. I know when you are working nicely, I'm very happy. So that's why. Okay, fine. Now it's more 11:15. We'll wind up. Good night then.
Thank you, madam, and thank you,
Thank you,
Dr.
madam.
Shobana, for very interesting presentation.
Madam.
With that, we will end up for today and hope to meet you all again another 2 weeks' time. Good night.